make you approve that. All right, so first thing we're going to do is I'm going to share my screen. And we're going to go with the schedule. So you can see, I'm going to downsize us. This is the schedule I've kind of made for this course so far. So us, me, AR Customized Training, and Ely Ambulance is putting this on because we have to be licensed through an ambulance service or a training facility in order to do this class. So today is June 1st. We're going to be doing Chapter 1, which is Intro to the EMS Systems, Chapter 2, EMR Safety and Wellness, and Chapter 3, which is Medical, Legal, and Ethical Issues. And then on a Monday at 8 o'clock, you guys will get an email from me for our June 8th topics, outlines, and PowerPoints to look over prior to class. So just take a look at this, which is in your email, and you'll see what we're doing each week. There are 2 weeks that are going to be on your own. First one being June 29th, because we have to also do the NIMS 100 and the NIMS 700 that we'll get to eventually here. So I'll have to have those on file in order to give you guys your certificates. All right, so the next thing I'm going to bring up is outlines. So I'm creating these for each course like day, just so it's easier for you guys to kind of look at what we're talking about in each of these chapters. Are kind of broken down. It's a good reference for you as well if you have to go back and look at some of these chapters. So this is just kind of breaking down the PowerPoints I'm going to talk about and talking about like the highlights and things I want you to kind of remember and go through maybe prior to class and or as a reference after class is done, so you don't have to sit there and dig through all the PowerPoints to find what you need. So this one is chapters 1, 2, and 3, specifically for today's class. All right, so I'm going to get rid of that guy, as you have those in your email, and I will do those each week for you. So I think we will bust into any questions so far from my audience out there? No? Okay. All right, I think we're going to then bust into chapter 1. If you have questions, just let me know along the way. You can always type them also into the chat. And once I'm done with the chapters, I'll take a break and we'll look at questions for each chapter as well. So I'm going to share my screen with chapter 1. And you are seeing a PowerPoint, correct? We're going to be doing this from the beginning. Let's see if I can. I want to use the presenter view on this. It won't let me use the presenter view. Yeah, okay. I'm gonna go back then. I'm just gonna roll with it this way so you guys can see the bottom part of what I'm gonna be kind of reading as well until I can figure that part out. Or let's do this. I'm gonna stop share. I'm gonna pull up my PowerPoint and that part. I guess we'll just roll with it the other way. Where did me chapter 1 go? We'll just share it this way. So I'm assuming you can see this PowerPoint. We'll have to get this kind of figured out. I'd like to put it in the presenter view so it's a little bit bigger for you. But if you're on our laptop, it should be okay, which I think most people are going to be on. So chapter 1 is the intro to the EMS systems or emergency medical services. Topics that we're going to cover in this chapter are the EMS system, the classic components of that system, emergency medical responder practice, like what we do out in the field, how we should be presenting ourselves, and then the quality improvement aspect of it. So intro to this, as a first responder, we are a vital part of this EMS system. We arrive first on scene. We are trained to address those life-threatening situations, prevent further injury and harm in the first few minutes that we're with these patients who are suffering from an illness and or an injury. The care that we provide is going to be continued by the ambulance service that comes and then en route to the hospital and then handed over to definitive care at the hospital as well. So we come from a lot of different backgrounds. Here with independent or the in-home harmony, you guys are coming from home healthcare companionship. We also come from law enforcement, firefighting, industrial places. Mines have their own first responders, all of that kind of stuff. So a lot of different backgrounds coming into this as well. A lot of people being first responders out there. So the EMS system as a whole, we are part of a larger EMS system as a first responder, or EMR. EMR is Emergency Medical Responder, which is old school first responder. We're a part of that large EMS system that starts with the bystanders calling 911, calling dispatch, and it ends with us handing that patient over to the ambulance, who then hands them over to the emergency department staff at the hospital for definitive care. Dispatchers often are taken for granted. Their role in this is, and we'll talk about their role in this a little bit coming up here, is pretty critical as well. So 911, when somebody calls 911 for assistance, say you're at a client's house, you call 911, you're going to enter into that emergency response system. System is going to start with a phone call that you make, either directly to EMS or 911, which is usually the case, 911. These calls are answered at what's called a public safety answering point. They receive the call from everybody, and then they call police, fire, EMS. So many of the people who answer these calls, they are also trained emergency medical dispatchers. So they do have a medical background, either EMR, first responder, paramedic. So they can provide really valuable information to us as responding units. They can provide information to you as the lay people out there, as first responders, and kind of guide us through situations to prevent and provide some of those life-saving medical instructions over the phone to us before ambulance gets on scene. So the EMS system has 4 levels of training. This is all put on by the National Registry. They have updated these, and this is across the board. Most of the states run with these 4 levels of training. So basic level is your EMR, which is Emergency Medical Responder. This is usually about 40 to 60 hours of training. Our class is going to be about 48 hours of training. EMT, Emergency Medical Technician, this is around 150 hours of training. So it introduces more trauma care, more medical, more pharmacology, other topics that are required for that basic back of the ambulance kind of operation. The next level up is Advanced EMT. So this is going to be IV skills, medication administration, advanced airway placements like ET tubes, and then some types of assessment techniques. And then the highest level of training out there is going to be the paramedic. So these are going to be different medications, ALS, monitoring, interpreting the EKGs, ECGs, and with minimal contact with a physician or outside help. So they're the highest level of care as ALS, which is advanced life support. Classic components of this EMS system. So we have what's called a tiered response. So all the different types of EMS systems, they come from different areas. Like we have up in Ely, we have private ambulance service. We have Morse Fall Lake first responders. We have Ely first responders. If you go down more towards Hibbing and Virginia, they're out of the fire department and the fire service. So there's fire department, third service, municipalities, private ambulance services. There's also hospital-based systems that are out there that Ely used to be. We go with what's called a tiered response. This is a system that has more than one level of response. It consists of law enforcement, fire. They provide first response until first responders arrive, ambulance arrives on scene to take over that patient care, and then transport that patient to the hospital. As EMR, sometimes you're paid, sometimes you're volunteer, sometimes you work for the fire service, sometimes it's an industry. It depends on where you live around the country. On each state is a little bit different. Ambulance wise, those are the providers that care the patient with transporting them to the emergency department. And then you have the emergency department at the hospital, which is providing that treatment and diagnostic services by the doctors, and then admitting them, further testing, transporting them out, that kind of thing. The components of these systems. So with us as EMRs, we're first on scene, and then ambulance is going to come with EMTs, potentially paramedics on board that ambulance. They're going to transport them to a specialty care center if one is available. The specialty care centers that are out there are trauma centers. These provide around-the-clock availability of a physician specialist, like an orthopedic or a neurosurgeon, as well as operating room 24 hours a day. So our nearest trauma center that we have up in our area is usually typically Duluth is where we send people. So these are patients with significant trauma, often are saved with surgical interventions and benefit from those places. There's also cardiovascular centers. So these are going to be providing specialized care for patients suffering heart attacks, STEMIs, that type of thing. And a lot of times for these specific things, trauma, cardiovascular, burn, stroke, we're calling in alerts, we're calling in air medical to get them to these facilities quicker. Primarily our area, Hibbing, Virginia, Ely. We're sending people to Duluth. St. Mary's is trauma, cardiovascular. They have the cath labs there. Pediatrics is also going to be St. Mary's, so dealing with specialized care for children. The burn center is going to be Miller Dwan in Duluth. So people that have suffered severe burns, we're going to be sending there. And then stroke centers, again, St. Mary's, so in Duluth, providing patients with special care after having a stroke. For regulation and policy, individual states have their own regulation. We are covered by EMSRB. Well, it was EMSRB, now it's OEMS, so it's the Office of Emergency Medical Services. That got switched over about a month and a half, 2 months ago. They revised the whole board. It used to be the EMSRB, Emergency Services Regulatory Board, which is now the Office of EMS for Minnesota. That's our governing state board. They're going to govern the EMS system. We have statutes that we have to follow, all of that stuff. They're going to provide leadership for us. So that's based on state. We also have the national registry. So there's like this broad national registry. We can do all this stuff, and we work for this state. The state only allows us to do this stuff. And then we're going to get down to like a regional area where our region, we can do this stuff. And then our agency policy, like maybe gives us a little bit more with advanced directives and some stuff that our medical director wants us to do. So we're all governed by different statutes and different policies and regulations throughout this. For public information education, we do want to participate in this. We can participate in prevention programs. We can get out there and do blood pressures on people, and we can sit at events, and we can instruct people how to do stuff, and we can do CPR classes, and we can do all kinds of stuff. Just providing them access to us. So how do they access their EMS system locally? And talking to the people that are out in the field doing this stuff. For medical oversight, each EMS agency has a medical director. So a physician that is a medical director that oversees clinical activities. This medical director is the one that is in charge of writing the protocols typically for us, setting those offline protocols, which we'll get to what that means after a little bit here. We have offline and online medical protocols that we can do. But we have a medical director that we have to be under as a first responder and above. Anytime you're with an agency, you're going to be have medical oversight with that medical director, which is a doctor. And then there's quality improvement, getting your evaluations. So each state has a quality improvement system in place for continuing the evaluation, upgrading its EMS systems, making sure we're doing everything up to par, making sure we're training like we should be, making sure our run reports are going good, just making sure all around that we are giving good, high quality care to the patients that are out in the field. For practice wise, so emergency medical responder practice, you are going to be, when we're done with this, you're going to be eligible for certification at that level of EMR in our state of Minnesota. So it would be coming from the Office of EMS. I put you guys in the system. If you haven't yet created or haven't been in that system, I will walk you guys through eventually creating an account in that system so I can log you into our class. And then you're going to create an application when we're all done with this so you can get your certification for your EMR for the state. There's a lot of factors that determine what we're able to do as first responders. So as I was saying earlier, we have state legislation. So each state has a scope of practice written into its legislation. This is going to determine what we're allowed to do at that first responder level. We have state EMS agencies. So each state has an organization that oversees EMS within the state. That's going to be our Office of EMS. They oversee training requirements, issue certifications, our licenses, all of that stuff. We have regional or local agencies. Our regional agency up here is Arrowhead EMS. And obviously our local agency would be whoever you're working for at that time, volunteering or paid or whatnot. So some areas also have agencies on local or regional levels that oversee EMS activities, which most places will. Medical oversight, again, that's the role of the physician medical director, is a vital part of that EMS system. They are directly involved with quality improvement and developing protocols for us and what we can do and what we can't do. And then it's going to come down to agency rules and regulations. So as first responders, we come from a wide range of agencies. Some are paid, some are volunteer. So regardless of what type of agency that we're with, these rules and regulations are going to be following us, so we know what we can do, what we can't do. So some of our responsibilities and roles as a first responder, and as you guys going into clients' houses, you want to make sure that your equipment is ready, clean, working order. It's with you. It's all good to go. Your safety is paramount with this. Personal safety is always the first thing we think about. Like, you walk in, is the scene safe? You're walking up and making sure everything is safe when you get there. Followed by the safety of other people, your fellow responders, then the patient, and then the bystanders. So proper steps to protect yourself and others from dangers at a scene that you might be getting involved in. Scene evaluation, size up. So after taking that personal safety steps, making sure the scene is safe, you want to evaluate that scene for hazards, fires, dangerous chemicals, violence, etc. Want to see how many people are in there, what's the number of patients that we have that are present in there, and then how do we gain access to that patient? If we arrive on scene, can we just open the door? Do we have to knock on the door? Is the door locked? We have to try to get in. Is the person trapped in a vehicle? Is it a dangerous situation? So just gaining access to that patient. So making sure equipment is ready, making sure it's safe to go in. We're evaluating that scene as we walk up to it. How many people are involved with this? How are we going to gain access to them? And then we start our patient assessment, which we're trying to be prompt and accurate with our assessment as a first responder, because we're going to be kind of making those initial decisions on, should we call air medical? Should we step up the ambulance? What should we do? Some of these are going to be like life-threatening conditions that we can assess for. Some are going to be less life-threatening and less critical, obviously. And not every situation is going to be a life-threatening situation. Some more roles, patient care. Based on our assessment findings, we're going to administer care within our scope of practice as a first responder. So whatever I'm teaching you in this course, is going to be technically your scope of practice. You would be covered by the Good Samaritan law. But whatever we're teaching you in here is things that you can do. You can provide emotional support. People remember how much you care more than sometimes the care you provide for them. They remember that you wiped their head with a washcloth. They remember that you talked to them. The continuity of care. Once you initiate patient care, your care is going to continue until the ambulance arrives, and they assume patient care after that. So we cannot abandon our patients and then just like let them go without handing them over to somebody of equal care or higher care to us. Medical legal standards in the patient care. That's the care that we provide that has to be in accordance with the rules and laws and regulations that are out there. We want to make sure that we're doing it like everybody else would be doing it. Public health. So we can contribute in a huge range of activities. We've done COVID shots, we've done flu shots, prevention demonstrations going on. So that public health, we can be part of that. So if you get an opportunity to do that, jump on in there. Community relations, again, that's kind of the same as public health a little bit. We can kind of represent ourselves in public as the EMS system, right? So you're with an agency, you're with a company, you want to make sure you're representing that agency or company to the best of your ability, making sure you're looking good, serving your community, just trying to do the best you can with what you have at that time. So all right, and then quality improvement. So QI, this is done in a variety of ways. Some of it's supposed to be helpful for people. A lot of people think, oh my God, quality improvement. They're going to come in, they're going to read all my reports, and they're going to ream me out. It's not meant to be punitive. It's meant to learn from it. Medical errors happen. They can be life-threatening events. We have to take steps to avoid this. Research plays a big role with this, which is quality improvement. So it's ensuring high quality. It's looking at all aspects of the agency, not just your specific run reports. There's committees that come together, and their goal is to keep us current on our knowledge and skills. If there's something that's not working, we need to change it up. Maybe we try a technique that's an old technique. We need to get that out of our system. So we need to train on this. We got a new piece of equipment that we need to train on, things like that. We want to make sure that we're just keeping up on our knowledge and skills. So when you guys are done with this class all together, you'll have 16 hours of refresher that you'll do every 2 years. And that's what you need to do to keep up your license, your certificate for your EMR, which isn't a lot of hours. It's 16 in 2 years. It's not a ton of hours to keep up on. EMT level is 40. Just keeps going up from there. But errors do happen in EMS because we're people, right? So errors are bound to happen because we're human. They can be life-threatening in this field, so we want to try to prevent them. So we want to make sure we're double-checking some facts, or we're double-checking decisions, we're double-checking medications that we're giving, we're double-checking everything. We can use our resources. We have pocket field guides, we have protocols, we have cheat sheets that we can use. So if you have resources in your bag, use them. We use them all the time in the field. Question assumptions, keep an open mind. Sometimes things aren't what you think. So just keep an open mind about stuff. Ask for help when you need it. If there's somebody that's on scene with you or in that room with you, get their input, ask opinions, talk it out, see what's going to work best. We do that stuff all the time. And then debriefing and looking for ways to improve. If you think something didn't go right, maybe we look at ways to improve that process, or what decisions were made and what could be done different next time. So those are some errors in EMS and how we can prevent those. And then we have research. Research is always continuing, it's changing. 25 years ago, when I took my EMT class, it was, what is a tourniquet? And we were doing 15 or 5 compressions on people in one breath. So things are adapting, things continue to change. And this is because of research. Primarily, a lot of this is done by military research. So CPR is one of the big things that have changed several times in the last few years. Tourniquets as well. Anytime we have somebody that has a hemorrhage that we can't control on an extremity, we go right to tourniquet. So we never used to do that. So things are changing, things are good. Patient care is always changing, research is being done, and us doing our due diligence and keeping up our knowledge and our skills is how this is going to ebb and flow and make patient care better. So, all right, so that's kind of the gist of. I'm going to stop sharing my screen here. It's the gist of it, chapter 1. Any questions on that one so far? No? Feeling good about it? All right. So let us do this. I'm going to get rid of that one. We are going to move on to chapter 2. So I'm going to share my screen. And we're going to go to chapter 2. All right. So chapter 2 is emergency medical responder safety and wellness. So with this one, our topics are going to be scene safety, which we just talked about, super important, protection from disease. So we have our bloodborne pathogens, airborne pathogens, stress, death and dying, lifting and moving patients, and patient restraint. So we're going to start at the top here. We'll start with scene safety. So in general, this is a pretty safe profession, but from time to time, we're going to come across stuff that could pose a danger to us, potential violence, hazardous materials, other scene hazards going on. We just want to make sure we're doing our scene size up and making sure that scene is safe before we go in. So we can use stuff like observation, just looking for obvious signs of violence, fighting, shouting, use or threatening of weapons that's happening, large unruly crowds, people fleeing from the scene, running away, drug or alcohol use by the patient, bystanders. You see stuff laying around the scene that you're in. We can use things like cover and concealment. So when a danger is present, one of the ways that we're going to protect ourselves is to take cover. So this is going to mean taking a position that hides your body behind something that is going to be thick enough to provide protection from you. Say a bullet's flying at you, cover is going to be covering your butt. It's going to be an engine block, a dumpster that's full, a tree, something that's going to stop that bullet. While it's unlikely that somebody's going to be shooting at you, cover should be thick enough to stop that. Concealment is hiding your bum. So simply means just hiding behind a bush, a large shrub, a car door, interior wall of a house, something that a bullet could go through, but it conceals you so they can't see you. It's going to hide you, but not offer you much protection at all. So we can use our cover and concealment. We can also distract. So when danger is present, it only makes sense that we get away from it. So distracting using a piece of equipment, other items on scene, blocking the aggressor, allowing more time for us to get away. We don't have to go into a scene that's not safe. We can run away from a scene that's not safe. That's not patient abandonment. That is keeping yourself safe. Once a danger is present, we're going to use cover and concealment, distraction. We're going to try to give ourselves time to decide an effective route to get out of there. When we go in places, we want to make sure we're not cornering ourselves to start with. We know where the exits are, that type of stuff to start with, but sometimes it happens. You get yourself in a corner, there's no escape route, walking aimlessly through a house trying to find the patient. So don't forget, we can also call for help, warn other responders that are out there, and we can run away. Drop your equipment and get out of there. We can come back in when it's safe to do so after law enforcement gets involved. Hazardous materials, we'll go through this a lot more in depth in chapters later on here, but looking for signs of the presence of hazardous materials. So tanker trucks, if you're on a highway, is there overturned or liquid coming out? Chemicals, placards. We're going to use what's called an emergency response guidebook if we have one of those. If vehicle hits a utility pole, those wires that are down, We want to make sure nobody's going into there. Sometimes vehicles involved in collisions are resting on their side or their top. We don't go in there. We're not going to gain access to that patient until everything is stabilized. We want to make sure we're not going into unstable vehicles, because what happens when we're in an unstable vehicle and that unstable vehicle then slides down a hill, we're going to go right down with it. Want to be aware that an unresponsive patient in a closed or confined space, again, there's some kind of maybe a chemical in there. We don't do confined spaces. That's a whole nother level of training that the fire department goes through to send people in those confined spaces. So we're not going to go in any of those. So we're not going to enter any of that without protective equipment and all the training that we need. So disease-wise, protection from diseases, we can kind of tell by looking at people how they feel, but we can't tell if they have a disease sometimes when we're looking at them. So we need to protect ourselves from some stuff. So we use what's called standard precautions. So standard precautions are your personal protective equipment, your PPE, your body substance isolation. It all means the same thing. So we're going to expect to encounter patients who have infectious diseases, they're bleeding, they're coughing. These are reasons we're getting called out. So we can treat these patients safely if we take standard precautions to protect ourselves. So these are just practices to prevent exposure to disease while we treat these patients. So we want to make sure that we take at least gloves on all patient encounters, is kind of the minimum. But if they're coughing and spitting, maybe we're putting a mask on them, we're putting a mask on us. These diseases can be transferred by a number of means, including body fluids, which is where your bloodborne pathogens come from, your airborne droplets, so your airborne pathogens. So blood, vomit, urine, saliva, all of that fun stuff can be transferred. Air droplets are those tiny droplets of the body fluids that are released into the air when the patient coughs or sneezes. If that's not protected, we can breathe in those droplets, and that exposes us to that stuff like tuberculosis and that type of thing. So think about back when you were younger, what vaccinations do you all have? So tetanus, that's usually every 10 years. Hepatitis A and hepatitis B, most people have gotten that in school or have that by now. MMR, the measles, mumps, rubella, again, we usually got that in school. If you're old like me, you had the chicken pox. You never got the vaccine for it. You actually had the disease because there was no vaccine for it, but there is now. And then the flu. A lot of people are getting their flu tests. You could add COVID to this list as well if you wanted to. And I think most of you guys, I was talking to Jules, and you'll be going in for a yearly tuberculosis skin test, which is called a Manto test that they're going to do on you. It's usually required for people working with home health care, hospitals, nursing homes, that type of stuff. So look forward to that coming up if you haven't done that already. So that's going to be part of your agency policy. And usually bloodborne airborne pathogens is required by OSHA at the state level, and it's usually every year we have to go through that. So I have a fun bloodborne pathogens video that will show you guys, an airborne pathogens video will show you guys. So during the response, your PPE or personal protective equipment is protecting yourself from that disease. Evaluate the scene, don or put on the appropriate stuff you think you should be putting on. If there's blood everywhere, maybe we're putting on the gloves, the gown, the glasses, the booties, we're putting everything on. If it's just, a simple taking a blood pressure on somebody or just doing a patient assessment, maybe we're just wearing gloves. If they're coughing and spurting, maybe we're putting our mask on and our glasses so we're not getting those droplets in our face and our eyes, and we have our gloves on. So we're just putting on the appropriate equipment that should be put on. Eye and face protection. So we got safety glasses, we have surgical masks, and we have face shields. So a lot of times with the masks that we wear at our level, they're going to be what's called N95, and those are approved by NIOSH and OSHA. So they're HEPA filters that keep us safe. So if you have a patient that is spraying or splashing the body fluids, right, we're probably covering our eyes, our nose, our mouth. If they're bleeding profusely, we're making sure that we're covering stuff up. Maybe we have a gown on. I always use like childbirth, which you probably won't be probably ever do in the situations you guys are going to be in, but I consider that a hazmat situation, right? Like everything is on, the gown, the gloves, the glasses, the booties, everything is on because there's a lot of body fluids coming out of there. We can wear safety glasses in combination with surgical masks. Those are going to keep us safe. Depending on what kind of glasses you guys have, remember if you turn to the side, sometimes stuff can still get in the side there. So be prepared for that. This is respiratory protection. So some diseases, like the airborne ones, like tuberculosis, those are those tiny droplets that are sprayed into the air, and we can breathe those in because the pathogens are droplets. They're very small. The simple surgical masks don't filter those particles out. So we are usually fitted for what's called HEPA, or high efficiency particle air mask, or an N95 mask, which is going to protect us against those little particles. They can't get through those masks, but they can get through simple masks. So that's the N95 or the HEPA masks are going to be protecting us from those airborne diseases. Gowns, protecting our clothes from being contaminated, because where do your clothes go at the end of the day? They go home, right? Unless you have a laundry facility at your workplace, your clothes are going to go home. So putting a gown on, keeping your street clothes kind of normal for when you go home is going to be good. Usually this is used for the major trauma cases, childbirth, that kind of stuff. So if you have a gown and it needs to be donned or put on, put it on. Infectious substances for exposure. Not every type of contact with body fluid constitutes an exposure. So like if you have a body fluid that's on your clothes and it's not considered an exposure, if you suffer an accidental needle stick with a dirty needle, have fluid splashed in your eyes, in your mouth, or have fluids come into contact with an open wound on your skin, that's considered an exposure. Being exposed doesn't mean that you're going to contract that disease or get that disease from somebody, but there's a lot of factors that go into this, with like the extent of the exposure, where you were exposed, whether or not you were in direct contact with it. So in the event of an exposure to the blood or body fluids, I'm assuming Jules is going to have a policy and procedure to follow for this for you guys. So what we want to do is immediately clean the wound, the exposed area, with soap and water. If you get in your eyes, start irrigating your eyes for like 20 minutes with water, and then follow your protocol that I believe Jules will probably give you guys. So, but clean the area first with lots and lots and lots and lots of water. We all know hand washing is good. So hand washing, we're going to use warm water. We're going to scrub. We're going to use a brush if necessary. Sing your little ABCs a couple times. You're going to rinse, you're going to dry, and then before you go and reach to turn that water off, while you're drying your hands, use that barrier device, the paper towel, wherever you have, use that to turn off the water. So then you're not re-exposing yourself to what you just touched to turn the water on. Hand washing is one of the biggest things that we can do to keep ourselves safe. And don't rub your eyes. All right. So far, so good. All right. Stress. Stressors that are out there. So this can be a stressful occupation. We're going to be exposed to situations that can cause a little bit of stress. We all deal with it, and we're all affected by it in different ways. Some of the common things that we're going to see out in the field are life-threatening situations, seeing the stress of patients, their family members, bystanders, people that are really ill or really injured, death of a patient, a coworker, multiple patients, like mass casualty instances going on, and kids. A lot of people with pediatric patients is a huge stressor and a trigger. We want to make sure we're remaining non-judgmental, focus on the patient care during the call. If a family member is yelling at you, they're not yelling at you, they're yelling at the situation. It can be a little bit stressful for everybody involved. So don't let those feelings hurt your feelings. They're trying to get it out, and we're just going to let them get it out. Some signs of stress that you should look for in yourself, your coworkers, family, friends, difficulty sleeping or nightmares. They start to get irritable, start to get sad, get a little anxiety, a little anxious, or they start feeling guilty. They start getting indecisive. They can't really figure out what to do. Maybe do this, maybe do that. Start losing their appetite, loss of interest in sexual activity. Oh, but wait, there's more. They're going to start to isolate themselves. They're going to lose interest in their work when they've always been interested in it. They're going to have an inability to concentrate. The feelings of hopelessness can start. They're going to start using drugs and alcohol. And then they're just going to look sick, right? Like signs of physical illness. They're just going to look like they're just down, they're dragging. So if you're seeing any of that stuff in people, talk to them, right? We don't have to go right above their supervisor and talk to their supervisor about it. The first thing we can do is go up and talk to them about it and see what's going on, see if you can help in any way. So dealing with it, everyone experiences stress in their life, in their career. There's no order that this happens in, and people can burn out. Lifestyle changes that can help: limit caffeine and alcohol intake, exercise regularly, find an outlet, get a hobby, find something to relax, go walk your dog, go on a bike ride, go drive around, find something that you really like to do and go do it. At times in your career, you're going to maybe feel the need that you need to talk to somebody about your feelings, then you should. This isn't a sign of weakness. People, I don't know why people always are like, well, I don't want to talk to anybody that's going to make me, seem like I'm weak or like I can't handle it. But that's what these people are there for. There's professional counselors out there. There's critical incident stress management teams that are out there. There's always somebody that you can call and talk to stuff about. Because we're going to be seeing things like death and dying. Death happens. Facing it is going to be part of being a provider. So grief is going to hit in different ways, and we'll talk about some of the stages of those, which I'm sure you guys probably know. So we are going to be called to people that are near death or who have died or who die in our arms. Often patients die despite the best efforts that we put into it. While we attempt to resuscitate patients who are not breathing and who don't have a pulse, sometimes people are just beyond saving and we can't do anything. We're doing the best we can, but we just can't do anything. So they may have sustained injuries that are too serious to recover from, been without a pulse for too long. Some of the stuff that we see, sometimes it's difficult to decide whether to start CPR or not. So we have to make that decision as a first responder, the first ones on scene. So these are reasons we're not going to initiate resuscitation on a patient. So if you're seeing like these signs of death, tissue decay, so peeling, discoloration, they smell really bad, we're not going to start CPR on that. Rigor mortis, they have stiffening of the joints. Usually it's the jaw and the fingers that go first. We're not going to start CPR on that. That's not compatible with life. And then other signs that are obvious signs incompatible with life: a decapitation, gross dismemberment, something like that, where you look at the patient and you're like, they are not alive. We're not going to start CPR on people like that. It's just going to give false hope. When we're dealing with this is our stages, right? Like I would like these to be in a bubble, because it's not like we're going to go through denial and then anger and then bargaining and then depression and then acceptance, right? So everybody deals with this differently. It's not like you're going to go through one stage and the next and the next and the next. There's no particular order with this. So I like the bubble aspect of another one better, but the denial part, these are patients and families. They deny that death is inevitable. Families may deny that death has occurred. You might deny that death has occurred. Like you're going to be going through this just like the families are. Anger, patients who are dying may lash out at others. Family members can lash out at you. It happens. They're not meaning it towards you. It's just, that's what it is. That's how they're dealing with their grieving process. You have bargaining. Patients and families may try to make a deal with a higher power or even a responder to escape death. We're not going to make promises that we can't keep. We're not going to be like, they're going to be okay, right? We're going to say stuff like, we're doing the best we can. with what we have, or, like we're not going to give them false hope with stuff. People are going to try to bargain for that. Depression, patients and family members both react with sadness and grief to certain situations, and you're never going to know how you're going to react until you react to certain situations or you're on a call. And then acceptance, that's sometimes people never get this, but the truly accepting impending death may be imminent. We can support the family, the patient, by listening to them and being non-judgmental about it. So those are our stages. Lifting and moving. And remember that these first, like, probably 6 to 10 chapters are just like introductory. We're going to be going through all this stuff again. We're going to be talking about, like, when we get into this lifting and moving part, we're going to be talking about backboarding. We're going to be talking about, like, we have 31 chapters to get through as we go through this. So we're going to be diving more in depth. These are just really broad overviews of a lot of this stuff. So lifting and moving patients. So with this, good body mechanics. We want to make sure we're not having back injuries. That is a leading cause of our disability related. Proper lifting techniques can help prevent those injuries. Making good decisions, making sure that we have enough people to lift and move, using good biomechanics. We just want to make sure we're not injuring ourselves in the process with this. If we have to wait for some more people to come because it's a heavier patient, we wait for more people to come. We call for a lift assist, call for the fire department, have them bring some people, etc. We just want to make sure we're not hurting ourselves. So when it comes to this, make sure you have good body mechanics. The lift is part of this. We're going to talk about each one of these, and then positioning patients for comfort and safety. So let's start with body mechanics. We want to make sure that we're keeping our back straight and in line. We grip firmly and securely with whatever we're lifting, a backboard, a patient, a gait belt, whatever we're lifting. Just body mechanics refers to that proper use of our body while we're lifting. Making sure that we have good footing, because up here, in our area, we always have good footing, right? So we want to keep our feet shoulder width apart. We're not going to twist while we move the patient or an object. That's going to tweak our back. And we're going to communicate and coordinate with others who are assisting in this process. So we're lifting at the same time. So if we have somebody on a backboard, we don't have somebody on the head end lifting and the foot end's not lifting, or the left side is lifting and the right side is not lifting. So we want to make sure we're talking to each other. Bariatric patients. So these are patients who are extremely overweight or obese. We want to make sure we use the proper decisions regarding our lifting capabilities with these patients. They are out there in our communities. There is special bariatric equipment that we can use, lifts, Hoyer lifts. There are different devices that we can use for this. If we need to get more manpower, we get more manpower in there. Again, calling the fire department, getting that lift assist from people so we're not tweaking our backs by lifting somebody up. The lift itself, again, communicating with others so that we are all lifting together on the same page, going 1, 2, 3, this is what we're doing. We want to keep the weight close to our body, make sure our feet are shoulder width apart, good solid footing, gripping that patient or the device firmly, and we're going to bend with our knees. We're not going to use our backs to lift, right? We're going to use our legs to lift. So want to make sure we're not tweaking anything there, no twisting motions or any of that. When it comes to positioning the patients for safety and comfort, we have a couple moves that we can do called emergency moves or urgent moves. When it comes to emergency moves, these are people that are at risk for starting on fire or being an explosion. If they're in an unstable vehicle, we don't have to get in the vehicle to get them out, but we can open the door and we can just grab that patient and get them out. Or if they're an unstable surface, we can throw them something and drag them out. If they're in cardiac arrest, we're going to want to move them from their bed to a firm, flat surface on the floor very quickly. And then the need to access other patients. So if we have to move them to gain access to somebody that's more critical, these are moves that we can do. We just need to document why we're doing them. In order to not be concerned about somebody with C-spine. It's like life over limb at this point. So like if I have to do CPR on somebody, I'm going to drag them off their bed onto the floor as fast as I can so I can start CPR. I'm not worried about C-spine injuries. So urgent moves, these are things we're going to do very quickly to get them into a more stable area, but we're not going to be concerned about C-spine with urgent move or with emergency moves. We can do a drag, grab them by whatever part of the clothes you got, grab them by an arm, grab them by a leg, whatever you have. If you have somebody in a tiny bathroom and you need to move them out to the living room where you have more room to work on them, drag them out there. If you feel comfortable and the patient is small enough, I would probably never do this because I would hurt my back. You can carry people out. This is usually done with the kids. So emergency moves. Reasons that we would move somebody not taking into account spinal precautions to get them into an area where we can work on them in a better environment. And life over limb at that point. So we're doing compressions, or we need to access another patient that is slumped over unresponsive, that type of thing. And then we also have what's called urgent moves. So urgent moves, we have a little bit more time with. We're going to take some kind of C-spine precaution, maybe put a C-collar on them, maybe manually hold their head. This would be people with inadequate breathing. Maybe they have an altered mental status. Maybe they're in shock or they're hypothermic. We can remove a patient from a condition that's going to worsen their condition, getting them out of that cold environment into a warm environment, getting them in from a warm environment into a cold environment if they're hyperthermia. So these are moves that we can do on people, but we have a little bit more time, so we can account for some C-spine. So we can be holding their head if we think they have a spinal injury, or we can put a C-collar on them if we think they have a spinal injury. And then we have recovery positions, positions of comfort. So anybody that we want to say, like you have a respiratory patient, right? They're not going to want to lay down flat. It's not going to be comfortable for them to breathe. So we're going to put them in what's called the position of comfort. Whatever is going to be, if they're stable, they can choose whatever position they want to be that they're going to be the most comfortable in. Sitting up, leaning forward, on their side. We're not worried about C-spine. So whatever position is going to be comfortable for them, we're going to do that. The recovery position, this is when we have patients who are breathing adequately, but they're not responsive. Maybe we're like, hey, are you okay? And they're not waking up really, but they are breathing on their own. We're going to place them on their side, like the guy on the screen. We can either do right side or left side. Doesn't really matter at this point. This is going to prevent vomit, any oral secretions they have from entering their throat and their lungs, so it can come out. And then we have the supine position. This is just laying on their back. So if we have a patient that is a traumatic injury, we're suspecting some kind of spine injury, we're going to put them on their back and provide manual stabilization of their head, put a C-collar on, prevent that movement. So we're going to put them in what's called the supine position, which is laying flat on their back. And we'll be going over all these again as well. I think that's next week or the week after. And then we have patient restraint. So when necessary, restraint is initiated to protect the patient, protect you, protect the bystanders. We just need to know our local protocol when it comes to this. We don't do this as a penalty or to be violent with patients. We just want to make sure we're doing it at the appropriate time, using the appropriate resources, and doing it appropriately, because we don't like to restrain patients if we don't have to. So we want to make sure that we're protecting the patient and others. Patients may require a variety of different reasons to be put restraints on. Regardless of the reason, it's again not done to prevent injury to the patient and others. Our safety is always going to come first with this. Restraining patients can result in an injury to one of us as we're doing this. The legal right to restrain someone is granted usually through state law. Most places are governed by a protocol for this. It should be a coordinated effort when we're doing this between 4 or 5 people. Like, you have the head, you have the left leg, you have the right leg, you have the right arm, you have the left arm. You all kind of go on one command and you take that person down. slowly in a coordinated effort, so we're not hurting us or the patient. So when the order is given to restrain that patient, we're going to advance swiftly and decisively towards that patient. You're going to grab what you need to grab, and we're only going to restrain that patient with soft restraints, typically. And we always want to do it face up. We don't want to put the patient face down. This is going to be difficult to monitor their airway. It can lead to fatal breathing problems. Sudden calming of the patient could mean that their condition is deteriorating. So we want to make sure when we're doing this that the patient is also face up. Okay, that's a lot so far. I'm going to stop sharing my screen. How are we doing so far? Oh,
No, it's good. Pretty, I mean, fairly basic, but a lot. Yeah, it's a lot, but fairly basic information. So I'm good.
all right. I think what I'm going to do now is we have bloodborne and airborne pathogens videos. Yay! Maybe. Anybody, do you need a break quick?
I can go either way with that.
Yeah, why don't we
Yeah, why don't we
take like a 5?
take like a 5? Okay.
Recording in progress. Share my screen. We're going to move to chapter 3. Chapter 3 is going to be medical, legal, and ethical issues. So topics for this chapter are going to be providing legal and ethical care, advanced directives, which you guys will probably be dealing with some of these patients, ethics, liability and negligence, and EMS at the crime scene. So we'll start with providing legal and ethical care. So as a first responder, we operate by authority of the state, regional, local scopes of practice that regulate us and our protocols. Again, a medical director provides that medical oversight. They either develop protocols, which are offline direction, or we can get in direct contact with those providers and use that as online direction. I'll talk more about this coming up too. We have to have consent to treat. So at times, this consent is going to come in different forms, which we'll talk about. So from the moment we approach a patient to the moment we transfer care to the EMTs, legal and ethical considerations are going to kind of weave their way into our care and our decision making in our patients. So things that we need to think about. Do we need permission to help someone? Yes, we do. We need consent to treat people. Can we treat a minor without the consent of the parents? This is one of the situations where we can. So if we're called to the scene of a child that's having an allergic reaction, the babysitter asks us to give the child a shot to make them better. That is within our scope of practice as a first responder. We can treat that. Can we let somebody die? You arrive on scene of a call, Somebody appears lifeless. A member says, please don't do anything. He has cancer. Let him die in peace. What do? Can we let somebody die? These are all like the answers are coming up here. You're out with your friends after work. They saw you on the highway at a car crash earlier. Tell us what happened. Can you discuss that detail with them? Not really, right? We'll get to what that's about. So our scope of practice, this is a set of rules, regulations, and laws that designate how we legally function as a first responder. So in some states, again, one law defines how we practice as an EMR, our skills, interventions, things that we can perform. Other areas may have a regulation at the state level, as well as regional, county, or local level. They all contribute to this scope of practice that we have. This is all the stuff that we can do as a first responder. That's our scope of practice. When we respond to a call, we're then governed by protocols. Protocols are those written guidelines that describe appropriate assessment and care in specific situations. Somebody's having an allergic reaction, we give them an EpiPen. Somebody is having this, we do this. So those are our different protocols that we're going to abide by. We have what's called offline medical direction and online medical direction. So the medical director of our agency plays that vital role in ensuring that we deliver high quality and appropriate care for our patients. Our medical director is responsible for developing the protocol that guide our practice in these situations. The protocols are also often called offline medical direction. They're written down. We don't have to make direct contact with them. This is an order that we can follow. Somebody is having this is what we do. It's a protocol set up, an offline medical direction. There are times, though, that we might need to call somebody and talk to them and see what to do. So we've done some of the offline stuff. We're maybe not sure what to do. We can get online, on the phone, on the radio. We can get on something and consult that medical direction for advice. That would be the online medical direction part of this. Consent. We do need consent. So we need permission to assess and provide care to patients. Gaining that permission is called obtaining consent from these patients. So if a patient is unresponsive or if the patient is a minor with no caregivers around, we can treat those patients under what's called implied consent. That allows the law that allows us to do that is the assumption that that unresponsive patient or the child's caregivers would want us to treat that person. So this is implied consent. Express consent is when the patient gives us permission. Hey, my name is Alyssa. I'm an EMT. Can I help you? Yes, you can help me. That is expressed consent. So in order to do that, the patient has to be old enough. They have to have the mental capacity necessary to make that decision. They can't be impaired by alcohol, drugs, or an effect of their illness or injury, like an altered mental status, a stroke, stuff like that. So determining if that patient is capable of giving consent can be a challenge sometimes. So us as first responders, we can do the best we can. We can have the EMTs and paramedics coming behind us that can help us in these situations. Maybe if we can't get consent from somebody, generally a person who is competent and they're able to understand what is going on, they are able to give consent. And then you have emancipated minors. Some patients who are under legal age may be emancipated. This means that a court has ruled the child is legally considered to have their own rights as an adult. So they can then make that decision on their own. Maybe a formal court order may be allowed in some areas if minors are married, if they're pregnant, have children, or in the military. They can give their own consent for their own care. They don't have to have the parents' permission. People can refuse care. If a patient does not consent to care, this is called refusal of care or patient refusal. Patients have the right to refuse assessment and or care as long as they meet certain specific criteria. They have to be an adult. They have to be able to understand the consequences of what they're refusing, and they have to be able to make that informed decision. If a patient, sorry, If a patient consents to our treatment but then refuses transport and continuing care with the ambulance when they get there, we've done our part. The EMTs at that level are going to get their refusal of care. But if somebody does refuse, we have to make sure that they're an adult. We have to make sure that they're able to understand the consequences of the refusal. Like, you're having a heart attack, you could die. We can tell them stuff like this. And they have to be able to make that informed decision. They can't be impaired or anything like that. With the refusals, this is a significant cause of liability for providers. Patients who refuse care only to have their condition deteriorate may still sue us, yay, who are people at the scene that obtain the refusal, the agency that you're with. A patient should not be allowed to refuse care in certain situations. If that patient has an altered mental status, we can take control of that patient. If they're under the influence of drugs or alcohol, they can't make that decision. And if their judgment is impaired due to their medical condition, we can kind of override that with, if we need law enforcement involved, we can get law enforcement involved, get a family member involved, but we can take over under certain situations if they're not able to state what they want. So these conditions don't give us the legal right to force a patient to accept treatment, but we have to keep in mind that we can be sued if the patient wasn't capable of refusing care at the time of that call. So it's a dilemma that we can potentially face, and you're going to face it eventually. Situations like this, we can get the ambulance involved as well. We can get law enforcement involved. We can get medical direction involved. We can get family involved. So, all right, confidentiality. We've all heard of HIPAA. We all sign this stuff every time we go in. So when we respond to a call, we find patients who are in need of our care. They're going to be telling us very personal information about themselves. Sometimes it's embarrassing situations that they're in. They depend on us to maintain a strict confidence about what we see, what we hear, what we do. So one of the most significant laws regarding patient confidentiality is this, HIPAA, the Health Insurance Portability and Accountability Act. This law identifies protected health information, or what's called PHI, that cannot be disclosed to others except in certain situations. The PHI, or protected health information, is anything that identifies that patient, is uniquely identifiable to the patient, and that relates to the assessment and care of the patient. So it's pretty much everything that we're doing. So this confidentiality includes everything that we see and everything that we hear and everything that we do. And there are very severe penalties for violating this law. So when times are acceptable to disclose this PHI, or protected health information, if we're transferring relevant and pertinent information to others directly involved in patient care. I'm a first responder on scene. I'm handing this patient over to the EMTs. I'm telling them everything I need to tell them. They're then going to hand that over to the emergency department and do the same thing. It's called transferring care. Upon patient approval to insurers and those responsible for payment, so billing, they're going to get this information. And then operational reasons within EMS agencies, including our quality improvement and doing our quality assessment, our quality research. It is mandatory reporting situations such as crimes of violence, abuse, or public health situations, and these are legal documents that can be also subpoenaed into court. So think about when you're writing this stuff, the world can see this potentially in the future. Maybe it's 10 years from now, maybe it's 7, maybe it's 20. It can always come back. So make sure you're writing stuff down that's factual and legit. And we'll talk about patient care reports as well. Advanced directives. So these are used to define the healthcare choices of patients in the event that they are incapacitated. There's state, regional, and local protocols that dictate the circumstances in which advanced directives can be honored. This is a pre-hospital do not resuscitate order. There's also called a DNR, DNI. So a do not resuscitate, do not intubate. There's post orders. There's all different types of pre-hospital stuff that we can be part of. These are some of the common ones. So advanced directives, we have the DNR, which is a do not resuscitate order. It's requested by a patient and signed by their physician based on the futility of resuscitation should the patient's heart stop. How If somebody stops, they start CPR on somebody, what's the point of that in that patient? Most DNR patients have some kind of terminal illness. The families of these patients are instructed to present that DNR to the personnel, like us as first responders or the EMTs, paramedics, in order for us to honor it. We have to see it. When we examine a DNR, if it's not signed by a physician, it can't be expired, or it doesn't include specific instructions, we're going to start resuscitation efforts. So that's a DNR. A living will. This is a document that provides directives about the patient's wishes in regard to medical care in the event they're unable to state them for themselves. So a living will is not signed by a physician, unlike a DNR. So a DNR order has to be within, it's not expired, it has to be signed by a physician and include orders. Living will is just, this is what the patient would have wanted. Durable power of attorney, this designates an individual as a surrogate decision maker if a person suddenly becomes incapacitated. Nothing to do with their health. The healthcare proxy is similar to that durable power of attorney, where the healthcare proxy is assigned decision-making capabilities to issues regarding healthcare only. So if they have durable power of attorney, healthcare proxy, it can be two different people. So they're determining the healthcare only on that side. These are just Minnesota's advanced directives, some links that you guys can have for those if you want to do a POLST or a DNR. Ethics. So ethics are based on morals and grounded in the concepts of right and wrong. Ethics guide our decision making when there's no specific law or regulation. It's like what we feel we should do, right? So what is considered to be ethical is much more difficult to describe than what is based on science or law. Ethics is going to help us define what we should or shouldn't do. Basically, to do the ethical thing is treat others how you would want to be treated, right? We've all heard that. Ethics are based on morals. Morals are attitudes based on the concepts of right and wrong. So having some of these traits like being honest, right? With patients, with hospital staff, with your documentation, being kind and compassionate, treating patients how you would want to be treated, and being a patient advocate, helping patients solve their problems or be heard. They cannot do that for themselves. So making sure that you're that person that is standing up for your patients and being an advocate for them. Liability and negligence. So we're going to talk about things like abandonment and negligence and breach of duty and duty to act and all that fun stuff. So we have what's called tort. Tort is a wrongdoing, which is a legal action that can be brought to you in court. We call it tort court, which is civil court. Most common charges against EMS responders are assault and battery because we want to help people, right? So we're touching them, even though they say I don't want patient care. So we're getting charged with assault and battery. So anytime we're forcibly transporting a patient to the hospital against their will, that's assault and battery. Two of the main areas where the EMS responders are exposed to liability are abandonment and negligence. So abandonment, this means leaving a patient without turning care over to another provider or medical professional of equal or greater training than yourself. So as a first responder, I can turn that patient over to another first responder, an EMT, an AEMT, a paramedic, a nurse, a doctor. As an EMT, I cannot transfer that patient care to a first responder. It's a lower level of care. It has to be your level of care or above. Otherwise, it's considered abandonment. Negligence is failing to follow a standard of care that causes or worsens a patient's injuries or conditions, both physical or emotional. So I show you how to do a technique in here. I talk about this and you do it the opposite way. That would be negligence on your part because you weren't taught that way how to do it. It's a standard of care that we have to follow. These lawsuits can be prevented by acting in an ethical and moral manner when it comes to doing our patient care. The four components of negligence. So in order to prove that you were negligent, all four elements have to be proven. So you had a duty to act. So the provider had a duty to act. This means that the provider was required to perform care by law, the job, duty, or expectation. You breached that duty. So failure to perform a required assessment or a treatment, or failure to perform an action correctly. Harm was caused by that, and that can be physical or emotional harm. And you have approximate causation, meaning that the harm was caused by an action or inaction that you took. So all four of these elements have to be established and proven in order to be liable for this. So you had a duty to act, you breached that duty, you caused harm in somebody, and it was either by your action or your inaction, which is the proximate. All right, crime scenes. Last topic of the night. We're not going to see this very often, but we will run into this from time to time. We want to just kind of avoid destroying evidence the best we can. So us at a crime scene, eventually we're going to be called to this. When we're entering, we have two main goals. We're going to provide patient care and preserve the evidence. As a general rule, we're not going to touch anything unless it's necessary to provide the needed patient care. So things like fingerprints, this is evidence, right? Fingerprints. There are little moistures and oils left behind on the surface. Touching the surface may smear fingerprints and ruin potential evidence. So preserving fingerprints and avoid touching anything at the scene unless you absolutely have to. Blood or bodily fluids. Fluids can be examined for blood type, DNA, pattern of spatter, a lot of different things that can be looked at. When on the scene, we're going to try to avoid stepping in any fluid and be aware of fluids that are on the walls so we're not smearing them. If there's clothing that can be cut off, we're going to place clothing in different places to avoid contamination and cross-contamination between samples. For wounds, when exposing wounds on the patient, avoid cutting directly through a knife hole or a bullet hole. We can cut around it, try to go like 6 inches around it. Conditions at the scene, making mental notes about the scene and what we see, reporting these observations to the police after you complete your patient care. And then statements at the scene. While caring for the patient at the scene, we may hear the patient or others make statements that might be a confession, a threat, other information that's pertinent. We can write that down and let the law enforcement know. Tasers, these are a device that use electrical current to disrupt muscle control and incapacitate a violent individual. The device is now widespread, used by everybody, majority obviously cops. Most individuals typically recover from a taser use quickly and without serious injury, but we might be called out to somebody with a probe in certain areas. We want to make sure the scene is safe for us. With somebody that's been hit by a taser probe, obviously there's been a situation going on. We want to make sure that we are providing for our safety first. The patient is likely to be restrained probably when we arrive on scene, but it can be violent or become violent again. We want to make sure that the patient has airway, breathing, circulation. If the event of a coexisting medical problem or there is an in-custody death happening, always perform ABCs initially. Carefully monitor them throughout the call to make sure we're keeping an open airway, making sure they're breathing, making sure they got a good pulse. We're going to assess the patient's complaint and injuries as we would any other patient. And we're not going to remove taser electrodes unless we've been trained to do so. In some areas, you will be trained to do so. And then we are mandated reporters as first responders. Child abuse or neglect. We see domestic violence, elder abuse, sexual assault, gunshot wounds, other violence, infectious diseases. When mandated to report, we may disclose appropriate information to authorities, and we're not subject to the confidentiality laws. Failure to report, we can be held legally liable, and have a penalty for this. But we need to make sure we're documenting stuff and documenting objectively and making sure that we are passing the word on things that we're seeing out in the field to the higher ups as we go. So, all right. Oofta. So far, so good. Whew. All right. I'm going to stop recording.